All right, good afternoon, everyone. Thank you for tuning in to my talk, which is part of the Hepatology and Liver Transplantation webinar series here at the University of Colorado. For those in the audience who haven't met before, I'm Rice, and I'm a transplant hepatologist here at the University of Colorado. I completed my medicine, GI, and transplant training here after doing medical school at the Medical College of Wisconsin. And the topic today is the approach to alcohol use in the context of transplant. This is a hot topic in liver transplantation with significant variance between centers and even providers. There is significant stigma and misinformation surrounding this topic. So my goal today is to provide objective data and a framework for providers, including primary care, addiction medicine, psychology, GI, and hepatology, to approach alcohol use in their liver patients. So here's our webinar disclosure statement. And here's the CME information for this talk. An email will be with a link to complete an evaluation and claim credit will be sent to you after the talk, so don't worry about anything right now. And personally, I have no conflicts of interest. However, I will say that I am not a mental health provider or an addiction counselor, and I don't pretend to be one. My approach to these topics is as a transplant hepatologist, and I rely heavily on my social work and transplant psychologist in my clinical care and practice. So here's today's learning objectives. We'll first assess the problem by reviewing current alcohol consumption patterns in the United States. Next, we'll define the types of high-risk alcohol consumption and how to treat them. Then we'll review how alcohol causes liver disease and the natural history of alcohol-associated liver disease. We will review indications for liver transplantation and alcohol-associated liver disease, specifically the growing evidence for transplanting severe alcoholic hepatitis. We'll review pre-transplant sobriety and alcohol counseling requirements, as well as which factors that predict post-transplant alcohol relapse. And finally, we'll review our center's alcohol high-risk pathway. All right, well, let's get into it. As many things in life, let's start with a case, unfortunately, that we've all seen before. So, all right, so we have a 28-year-old male who presents to established care in your clinic, and he reports 1 month of progressive jaundice, edema, as well as abdominal swelling. Denies any past medical or surgical history. He has no family history of liver disease or autoimmune conditions. Denies any new medications or supplements. Denies any recreational drugs now or in the past. He reports 2 to 3 alcoholic beverages per day for the past few years with previous social use before that. So let's send off some labs. And as you can see here, he has a low normal sodium with an elevated creatinine. He has macrocytic anemia with a slightly low platelets and an elevated white blood cell count. His LFTs are elevated in a mixed pattern with AST greater than ALT and a mixed hyperbilirubinemia. His INR is elevated as well. You get an ultrasound, which shows an enlarged liver with a heterogeneous ecotexture, nodular service, reversal flow in the portal vein, enlarged spleen, and moderate free fluid. The report states that this is consistent with chronic liver disease with possible cirrhosis and associated portal hypertension. So after getting these images, you give him a call back. And upon further discussion, he reports that the 2 to 3 drinks actually equates to around a pint of whiskey a day. And he says that he increased his consumption since he lost his restaurant job at the start of COVID, which somehow is now 3 years ago, basically this week. So no mystery here. This case is of alcoholic-associated liver disease with alcoholic hepatitis and possible alcohol-associated cirrhosis. Let's start off with a reminder of what a standard alcohol unit is in the United States. Beer should be 12 ounces at around 5% alcohol. So the 16-ounce IPA at the local brewery is more than a single drink to your liver. For wine, a standard unit is 5 ounces. So there's around 5 drinks in a bottle of wine. And finally, for liquor, a unit of alcohol is 1.5 ounces of 80 proof spirits. So to help better quantify a patient's alcohol consumption, I always ask them, how many days a week do you drink? When you do drink, how many beverages do you consume? And what is an alcoholic beverage for you? And if this doesn't elicit an accurate quantity, I do ask then, how do they purchase their alcohol to get a general sense of how much they consume in a week? So what actually changed during COVID that brought this topic to the forefront? So thinking back to the early days of the pandemic when we were wiping down groceries and putting our cell phones in plastic bags at work, one thing that stuck out in my memory is the response to Denver's mayor initial deeming alcohol non-essential and the lines that quickly appeared at liquor stores around the city. These lines, along with his quick reversal, say a lot about our society even before COVID. Since the start of COVID, according to a survey by the National Institute of Alcohol Abuse and Alcoholism, the NIAAA, around 60% of people increased their alcohol consumption, with only 13% decreasing since the start of COVID. And as you can see here on the right, there was a significant increase in alcohol sales after COVID. However, as you can see also, there was already a rise pre-pandemic. So prior to COVID, there was an increase in even prior to COVID, there was an increase in mortality from cirrhosis over the past around 15, 16 years. Specifically in young people, this was almost entirely driven by alcohol-associated liver disease. And so the pandemic accelerated an already a public health emergency. Looking at alcohol-related deaths in general during COVID, there was a 25% rise in monthly alcohol-related mortality. And unfortunately, this has not gone back to pre-pandemic levels. However, there is some hope as Gen Z, who are individuals born after 1996, appear to consume less alcohol than previous generations, but this data is obviously still early. There are many reasons that people increase consumption, such as loss of work, boredom, social isolation, worsening mental health that occurred during COVID. However, many of these individuals have not been able to reset their relationship with alcohol despite society getting closer to normalcy. So what is high-risk alcohol consumption? In America, around 140 million people consume some amount of alcohol. And of these, around 67 million drink in a binge drinking pattern, which is defined by the NIAAA as a consumption of 5 or more alcoholic drinks for males or 4 drinks for females on the same occasion. Heavy drinking, which is more than 4 drinks on any day or greater than 14 in a week for males, or greater than 3 on any occasion, or greater than 7 in a week for females. In general, remaining below this level will not lead to alcohol-associated liver disease. However, as we better understand the effects of alcohol on the whole body, there may actually be no safe amount of alcohol with any negative consequences. So when do people have a problem with alcohol? We used to call this alcoholism, but the term is now alcohol use disorder, which is meant to destigmatize and encourage providers and patients to treat this as a medical diagnosis. This is a busy slide here, but here are the symptoms of alcohol use disorder. Starting with alcohol is often taken in larger amounts and on longer periods than intended. Other symptoms include persistent desire or unsuccessful efforts to cut down, spending a great deal of time obtaining, using, and recovering from alcohol, craving or a strong desire to reduce alcohol, strong desire to use alcohol, recurrent alcohol use resulting in failure to fulfill major obligations at work, school, or home, continued alcohol use despite having persistent or recurrent social or interpersonal problems caused by or exacerbated by the effects of alcohol. Important social, occupational, recreational activities are given up or reduced because of alcohol. Recurrent alcohol use in situations that are hazardous. Ongoing use despite knowledge of having persistent or recurrent physical or psychological problems that is likely to have been caused or exacerbated by alcohol. And finally, having symptoms of tolerance or withdrawal is defined here. So the presence of at least 2 of these symptoms indicates alcohol use disorder. However, this can be further quantified by the number of symptoms that a patient experiences, with mild being 2 to 3, moderate 4 to 5, and severe 6 or more. But how common is this diagnosis? Unfortunately, there are around 15 million Americans who meet criteria for alcohol use disorder, and around 1 in 3 Americans will meet criteria at some point in their life. Studies have shown that around 35% of patients with alcohol use disorder will develop some form of alcohol-associated liver disease. And doing the math, that's a lot of people. So how do we screen for problematic alcohol consumption? There are several validated screening questionnaires. Probably the most common is CAGE, which asks 4 questions, starting with, have you ever felt like you should cut down? Have people around you have people annoyed you by criticizing your drinking? Have you felt guilty about your drinking? And have you ever had a drink first thing in the morning? A score of 2 to 3 indicates high suspicion for alcohol use disorder. This test has a sensitivity of 75 to 95% and a specificity of 85 to 97% for detecting alcohol use disorder. Another easy screening tool is the Audit C, which has been shown to be more sensitive than CAGE. This questionnaire quantifies how often and how much someone drinks, as well as how often they binge drink. Cutoff score for audit C is usually a total of 3 points for women and 4 for men. And this leads to a sensitivity of 83% and a specificity of 90% for identifying alcohol use disorder. However, these are only screening tools, and positive results should prompt further evaluation with using full alcohol use disorder questioning and referral to an addiction medicine counselor if needed. But how do we screen candidates during the transplant evaluation, which is, I know, why a lot of you are here. So there are no established screening tools for transplant, but here's a general approach that providers use at our center. First, we ask, when did they start using alcohol, or when did they start drinking and why? Then when did you increase your drinking to your current level? And specifically, when did it become daily and why did that occur? When did you stop drinking? If they have stopped drinking, what prevented them from stop drinking before then? Were you ever told by a healthcare provider to stop? And did you at that time? When did you find out about your liver disease? And did you stop drinking at that time? Have you had any relationship, financial, personal, or legal problems related to alcohol? And any previous counseling or rehab? What type of rehab was that? And was it mandated? Anyone else in your household drink or have any problems with alcohol? And looking at these, as you can see, there's a lot of questions with specifically why follow-ups. And the reason for that is trying to understand a person's insight. So insight is a nebulous term, but ultimately we are trying to make sure that the patient associates their liver disease to alcohol and attempt to identify any treatable triggers prior to transplant. I tell patients that this is a liver transplant and not a life transplant. You have the same family, friends, bank account, job, all the stresses that occurred before transplant are going to be there afterwards, but you're going to feel better. And so taking care of these things now and treating your alcohol use disorder now as well as after transplant is essential. There are attempts to quantify insight, such as using the alcohol use awareness and insight scale. However, its clinical utilization is early. And as you can see, the questions assess how much a patient understands and owns up to the connection between alcohol and its consequences. So what do we do when we identify alcohol use disorder? So treatment of alcohol use disorder includes both counseling and medications. I won't get into the specifics because it's beyond my skill set and the scope of this talk, and it requires input from a mental health provider. However, when we do require counseling for transplant, is it at minimum individual counseling and not mutual aid societies like Alcoholics Anonymous. Beyond that, we defer to our mental health team and the patient's counselor, since there's no proven superior modalities for treatment of alcohol use disorder. Some recent studies, however, have shown that incorporating alcohol use disorder treatment with liver care in an integrated clinic improves abstinence rates. And several models exist around the country, which we can hopefully someday recreate here. Even more importantly, early alcohol rehab can prevent ongoing harm. In a study of patients who were admitted with alcoholic hepatitis, alcohol rehab reduced readmission rate, relapse, and death. So this is where an inpatient addiction medicine team is essential for expediting and facilitating rehab post-discharge. And this is also when patients want to delay the rehab or even delayed indefinitely, obviously. But this leads to conversations on the risk of ongoing use and relapse and evidence base that early is better than later. But what about medical therapy for rehab? So, for medical management of alcohol use disorder. So there is a role for alcohol use disorder pharmacotherapy, and this is despite the risks of adverse events in patients with alcohol-associated liver disease. Of the medications listed, the FDA has approved disulfiram, naltrexone, compressate, all for alcohol use disorder. However, none of these have been approved for alcohol-associated liver disease, and only baclofen has been shown efficacy and safety in alcohol-associated liver disease, but this was only a single trial. More research is needed before using these in decompensated liver disease. However, in more compensated cirrhotics even, these can be used safely if monitored closely. But who should be prescribing these medications for these patients? There was a national survey that showed that only 23% of hepatologists were mostly or very comfortable prescribing these medications. So this means that most of the prescribing does fall on primary care or addiction medicine providers to start and monitor for these. Unfortunately, this doesn't always happen. And in a large VA study of patients 6 months after their alcohol use disorder diagnosis, only 12% received behavioral treatment and 1% pharmacotherapy. So now, how do we monitor consumption and sobriety now that we've established that we should start them in counseling and start medical management if needed? While there are several different alcohol tests, the most sensitive and specific is the phosphatidylethanol or PEth test, which we use here in Colorado. PEth is a phospholipid formed by a reaction of phosphatidylcholine with ethanol in the RBC cell membrane. This is why we sometimes call it the A1C of alcohol. It has a half-life of 10 to 14 days, so will remain elevated for 2 to 4 weeks, but sometimes even longer with chronic repeat heavy use. A cutoff of greater than 20 has been shown to have a high sensitivity and specificity for heavy consumption. The only accepted false positive is a blood transfusion, but this only leads to a low-level positive. This is not meant to ultimately catch patients, though, but instead we use this as a catalyst for discussion. I always tell my patients that I'm ordering it with the goal of having objective confirmation of their sobriety if transplant is indicated. This does sometimes lead to patients admitting to use, but sometimes patients still do deny despite knowledge that we're getting an objective test to quantify their alcohol use. Unfortunately, this does commonly lead to transplant denial. Obviously, this lack of communication and insight, is worrisome in these patients. So briefly back to our clinical case. So, does he have cirrhosis? Ultimately, this is a common question and a difficult question because alcoholic hepatitis and cirrhosis can present similarly. Testing with labs such as the FIB4 or the AST to platelet ratio, as well as imaging, are not always helpful in the setting of alcoholic hepatitis because they lack sensitivity and specificity. This goes for non-invasive testing as well, because alcoholic hepatitis increases stiffness independent of fibrosis and can take up to 6 to 12 months for that stiffness to resolve, if at all. And so you could do a liver biopsy. However, this rarely changes management unless you're looking for a secondary etiology of their liver disease. In the end, does it matter? I'll argue that no, it doesn't matter in the care of these patients. And alcoholic hepatitis and cirrhosis can be treated initially similarly, and then it can be reevaluated after 6 to 12 months, depending on if they recompensate with sobriety. So briefly, alcohol-associated liver disease is a spectrum, which includes simple steatosis, steatohepatitis, severe form, which is alcoholic hepatitis, cirrhosis, and HCC. The liver is injured by metabolizing ethanol to acetaldehyde, which leads to immune activation, glutathione depletion, lipid peroxidation, and mitochondrial damage. This leads to inflammatory response, which is further propagated by alcohol-induced gut permeability, which leads to gut microbiome changes and gut translocation of bacteria. This inflammation leads to fibrogenic cell types, which ultimately lead to fibrosis and cirrhosis, as well as portal hypertension. So this injurious effect of alcohol in the liver is not linearly dose dependent, but there is a threshold beyond which these risk factors for serious liver disease increase, which is considered heavy alcohol use. This progression is affected by other modifying factors like genetics, sex, ethnicity, obesity, and concomitant liver disease. I do want to note the diagram on the right. So this shows a green arrow going from hepatitis to steatosis. So there is the potential for a patient with alcoholic hepatitis to recover and ultimately not have cirrhosis in the end. However, as we discussed before, this takes 6 to 12 months to really figure out which way the patient is going, and only occurs in around 20 to 30% of patients. So there's also no way to predict who will recover. So really, it's just abstinence in time. So what about alcoholic hepatitis, the severe form, as I said, of alcohol-associated steatohepatitis? This inflammatory process requires consumption of greater than 40 grams of alcohol for women, or 60 grams for men per day, which is around 3 to 4 drinks in the US standard alcohol units, for greater than 6 months. The onset of jaundice should be less than 8 weeks, and they should have an AST to ALT ratio greater than 1.5, with total levels less than 400 and a bilirubin greater than 3. We won't get into the treatment and scoring system since that's an entirely other talk, But remember that severe alcoholic hepatitis is a MADRS discriminant function greater than 32, and steroid non-responders are considered severe. And these are identified using the Lilly score at day 4 or 7 to decide if they respond or not to steroids. So what do we do about patients in transplanting for alcohol-associated liver disease? So even prior to COVID, alcohol-associated liver disease had become the most likely indication for liver transplant in the post-hepatitis C era. And even more recently, there's been an increase in transplant for alcohol-associated hepatitis, alcoholic hepatitis, which saw a huge jump during COVID, unfortunately. But when should you refer people with alcohol-associated hepatitis or alcohol-associated liver disease for transplant? So in alcohol-associated cirrhosis, some rough indications for transplant include a MELD score, which is the most common, over 12, should be considered for referral, as well as anyone with decompensations, regardless of their MELD score, have an increased risk for mortality and should be referred for consideration. Anyone with HCC should be considered as long as they don't have metastatic disease. And while MELD sodium and decompensations are important considerations, other things such as malnutrition and sarcopenia should consider referral as long as they aren't prohibitive and preventing the patient from preventing further frailty, which would prevent transplant. So these complications are not included in the MELD score, but they do have significant morbidity and mortality in this population. But what about alcoholic hepatitis? Are there any indications for transplant independent of cirrhosis? Well, in fact, there is. Here's one of the landmark studies for early transplant for severe alcoholic hepatitis. Inclusion criteria include severe alcoholic hepatitis with non-response to steroids. They further required that this event was their first liver decompensation. They also needed close social support, absence of severe psychiatric disorders, and there needed to be a universal agreement among providers for transplanting the patient. So as you can imagine, this restricted a lot of patients, and only 2% of the patients admitted for severe alcoholic hepatitis were selected for this study. Of those transplanted, though, they had a 6-month mortality of 77%. Which was significantly different than patients who weren't transplanted, which had a mortality or had a survival of 23% in that time period. In the end, 3 of the 26 patients resumed alcohol use. But what does that mean, and what does post-transplant alcohol relapse look like? So here's a study, a US study that looked at post-transplant alcohol consumption in patients transplanted for severe alcoholic hepatitis. They found 4 patterns. Pattern 1 in black represents abstinence post-transplant, which was 70% of people. Pattern 2 in green represents patients with abstinence, then late onset, non-binge or non-frequent alcohol use, which led to 6%. Pattern 3 in blue is patients with early onset, sustained, non-binge or non-frequent use, which was 15%. And finally, pattern 4 in red represents early onset, sustained, binge, or frequent alcohol use, which was 8% of patients. So you can see most patients do not return to alcohol, with only 8% returning to heavy use. However, another 20% did resume some amount of alcohol consumption after transplant. So what does this do to the allograft, and is this clinically important? So here's the Accelerate AH trial, which is a retrospective multicenter study for early severe alcoholic hepatitis transplant, in which the median length of sobriety was only 55 days, with a median MELD of 39. So this was a sick population where mortality was 70% at 6 months without transplant. So 1 year post-transplant in these patients, there was a 94% survival rate. And at 3 years, this was maintained at 84%. So good survival outcomes after these transplant. So sustained alcohol use after transplant did occur in around 10% of patients at 1 year and about 17% at 3 years, with a median time to relapse of about 25 months. In these patients, in patients with harmful or excessive alcohol use, around 32% of these patients did develop recurrent cirrhosis within around 4 years. 2/3 of these patients did die with a median time from cirrhosis diagnosis to death of about 1.1 years. So when these patients do get recurrent cirrhosis, they do have poor outcomes. Unfortunately, they also found that any amount of alcohol use after transplant was associated with a 3.5 times risk of mortality compared to being abstinent. So any alcohol is a big deal, but may not always lead to rapid graft loss. which is what we monitor a lot, obviously, in the post-transplant period. But in order to allow these patients to be successful long-term and allow this allograft to last a long time, ongoing treatment of alcohol use disorder after transplant is essential. So what about the 6-month rule that always seems to come up and seems to be kind of out there as far as people's understanding for sobriety? So this was actually developed as time to provide recompensation and potentially avoid transplant in these patients. There is no evidence that the greater than 6 months sobriety rule reduces relapse, and actually it leads to dishonesty and does not encourage active treatment of alcohol use disorder. Moreover, 75 to 90% of deaths from alcoholic hepatitis occur within 2 months of diagnosis. And therefore, you're excluding a large percentage of this population from ever achieving criteria for transplant, even though they may not drink after transplant, like 70% of the patients seen in that study. Since time doesn't predict relapse, what factors do then, and what do we use? So here's some protective and negative factors for relapse after transplant. The protective factors include insight into their addiction, social support, substitute activities, improved self-esteem or hope, perception of negative consequences of their alcohol use, so insight. Negative factors include psychotic disorders, personality disorders, family history of alcoholism, alcohol dependence and diagnosis, as well as repeat attempts at rehab, unremitting substance abuse despite physical or social consequences of alcohol, and as well as social isolation. You'll see these positive and negative factors come up later when we discuss our center's alcohol high-risk pathway. As with all things, someone developed a score to predict post-transplant relapse, which is called the Sustained Alcohol Use Post-Transplant, or the SALT score. It uses quantity of consumption, failed attempts at rehab, alcohol-related legal issues, and history of non-THC substance abuse to then provide a score. And a score of less than 5 has a 95% negative predictive value for sustained alcohol use post-transplant. How we use this in our transplant decision-making is not perfect, but it does provide some objective measurement to relapse after transplant. So what are the transplant requirements for alcohol-associated liver disease here at Colorado? When evaluating patients with alcohol-associated liver disease, they first must admit that their alcohol use, because if they're denying it, they either don't have alcohol-associated liver disease or they're in denial, which would be confirmed on PEth. So patients need to demonstrate insight, as well as a commitment to lifelong abstinence, as well as believe that treatment will be helpful in the care of their alcohol-associated liver disease. They need a lack of coexisting major uncontrolled psychiatric disorders or other untreated addiction. They need to be able and willing to engage in an evaluation process. And this can be kind of tricky because a lot of times these patients are very sick. This means that they can't have severe hepatic encephalopathy or be too sick to engage with our team, like being intubated or multi-organ failure. Historically, we required patients to leave the hospital to initiate alcohol counseling and screening. However, now with the alcohol high-risk pathway, they can potentially do this after transplant, which we'll talk about. They need strong social support. And for our patients who are tuning in from, or providers from New Mexico, this usually means that they need someone to commit to staying here locally for 3 months after transplant. So they also need no other contraindications to transplant, such as they need to be less than 70 years old. They can't have morbid obesity with a BMI less than 40. They need to have a BMI less than 40. They can't have other significant critical illness that would prevent transplant. So they can't have severe cardiopulmonary disease, prohibitive sarcopenia, malnutrition, or frailty. And they can't have any metastatic or uncurable cancer, amongst other things that can be identified during the transplant evaluation process. But these are just some rough contraindications that may come up in conversations with our team, either in person or through DocLine. So here is our alcohol high-risk pathway. As we reviewed historically, patients are required to engage in therapy and document sobriety. However, some patients are too sick and they can't survive their index admission or stay out of the hospital in order to achieve this minimum requirement. So we developed criteria for these high-risk patients, which can be either cirrhosis or alcoholic hepatitis. Importantly, this pathway has no sobriety time limit. These patients must have no psychiatric conditions, no major psychiatric conditions, no prior relapses, and no major complications of alcohol-associated liver disease or alcohol use disorder before this. This must be their first hepatic decompensating event, like the studies I discussed earlier. They must acknowledge the role of alcohol in their liver disease, so insight, and they can't have any prohibitive hepatic encephalopathy. And they also require unanimous agreement amongst our transplant selection committee. So as you can see, this incorporates the evidence-based protective and negative factors for post-transplant relapse, which we discussed previously. These patients need to sign an agreement that states that they will complete counseling after transplant, which also must be signed by their supporting hepatologist. For 1 year post-transplant, these patients will need monthly PET tests as well as in-person appointments with a provider. So to date, around 38 patients have undergone this alcohol high-risk pathway, and around 90% of these patients were sober at 1 year, which seems to be in line with other studies which I presented earlier. So what can you do as referring providers to help your patients be successful and get to transplant if needed? So it starts with screening, specifically early identification and intervention to prevent worsening liver disease due to ongoing alcohol consumption. So obviously it's a tough topic and patients can be guarded, but keeping an open conversation with these patients and screening for them can help you identify it early and work on it over time. You should always get a detailed alcohol history and assess their insight with their association between alcohol and their social and health problems. You should assess for protective and negative risk factors and potentially identify any ways to modify those if possible. You should discuss alcohol use disorder as a medical diagnosis. You should keep an open dialogue and use motivational interviewing to help your patients achieve sobriety. You should review that there's no safe amount of alcohol and alcohol-associated liver disease, and they should quit now. So this can be a tricky conversation, obviously, because there's a lot of concern about withdrawal and the medical consequences of stopping alcohol. So I always offer a referral to addiction medicine or medical detox if you're concerned about this, or even an admission to the hospital to help them get through this initial stage, because as you've seen, early intervention, early rehab is essential for stopping, as well as your support for them will go a long way for getting them to transplant. You should check a baseline path, even if they're still drinking, because it can show a reduction over time if they need a transplant before it goes back to zero. And then continue monthly PET testing to show objective sobriety, which is essential for getting to transplant in some cases. But one thing to remember is you're not expected to be a transplant hepatologist or a psychologist or a substance abuse counselor. If a patient is interested and motivated in quitting, please refer early for transplant, because this gives us time to optimize prior to transplant and use the resources we have to help them get there. But obviously, they first need to be interested in quitting and show interest and insight that they'll never drink again. So here's some resources that you can use. The NIAA website has educational and clinical resources for providers who are interested in learning more about this and how to help their patients. So Psychology Today is a good website for patients to find providers in their area that accept their insurance, which I know can be a big barrier. Fortunately, a lot of these centers do now offer telehealth and other options for treatment for patients who live in more remote areas, as we know in this region can occur, and limited providers locally. And then CEDAR is the addiction center that's associated with UCH, which provides addiction medicine, medical detox, individual counselors, intensive outpatient counseling, as well as inpatient rehab. So if you are in the UCH system, there's actually an epic order for referral, and they're a really supportive, great group of people there who can obviously help you troubleshoot this. So here's my take-home points from the talk today, that unfortunately, alcohol use disorder and alcohol-associated liver disease are on the rise, which is why we're even talking about this topic. Alcohol use disorder is a medical diagnosis and should be treated as such. And we should screen all patients for alcohol use disorder, but definitely anyone with new liver disease, such as steatosis, steatohepatitis, alcoholic hepatitis, or cirrhosis. So you should complete a detailed alcohol history and social history in patients with alcohol-associated liver disease. Alcohol use disorder treatment should be offered early and include both counseling and medication when appropriate. There is no 6-month rule. We encourage early transplant referrals in patients with insight and commitment to lifelong sobriety. And in select patients who meet our high-risk alcohol pathway criteria, transplant can occur even during their index admission without any documented sobriety. So here again is our learning objectives that we hopefully accomplished today. And obviously, I'm happy to take any questions that people have at this time. Thank you. So I have one question in the question and answer so far. So they're asking specifically about impact of false positives with PEth and things like cough syrup that contains alcohol. So this is a common excuse from patients, and they would have to drink significant amounts of alcohol. So this is consistent with moderate use, moderate to heavy use of alcohol with having a cutoff of 20. And so if they would have to be drinking daily multiple large amounts of cough syrup to equate to 3 to 4 alcohol use, 3 to 4 beverages a day. So in the context of false positives, really the only accepted false positive that we have is blood transfusions. And again, this should be a low-level positive because you're not replacing all the red blood cells in someone's body. And so this usually is a low level. I'd be given an arbitrary number, but usually what we've seen is in the at most in the teens to 20s, but sometimes up into the 30s. And let's see, another question just came in. Can you speak to more about the differences, if any, between binge drinking and daily drinking that would lead to alcoholic hepatitis diagnosis over 6 months? So alcoholic hepatitis does usually require daily or near daily drinking. It really is not like usually not a weekend drinker. It does require or a single event or a week or anything like that. However, a lot of times there is a preceding increase before the diagnosis. So usually this does require daily consumption and for greater than 6 months. The other part of this is that I hear a lot of times saying the patient stopped 2 months ago. Why are they getting worse? I did not get into kind of the specifics of the natural history of alcoholic hepatitis, but it does take weeks to months for you to kind of hit a peak with the bilirubin and the leukocytosis that commonly occurs with it. And so just because they quit a month or 2 months beforehand doesn't mean that it's not alcoholic hepatitis. And so obviously ongoing alcohol use is concerning, but even if someone has a negative PEth, if they have a strong history and it's consistent with alcoholic hepatitis, you still treat it as such. There is some instances where, again, a biopsy could be helpful, but I think that's a rare instance where really you see other features of liver disease and the history just really isn't adding up and the PEth is negative. All right, so here's another question from someone regarding hepatic encephalopathy be a contraindication to the high-risk pathway. What if the patient is much improved and resolved hepatic encephalopathy treatment? So good question. Really, it's more uncontrolled hepatic encephalopathy. So ultimately, if you can treat it medically, that would not be a contraindication to our alcohol high-risk pathway. Really, it's more that, we require our patients to, basically, non-legally binding, but sign something that they'll do this and acquiesce that they will do this after transplant. And if, while they might have supportive family members, if the patient can't tell us themselves, then they really can't fit our pathway, unfortunately. So here's another great question about our high-risk pathway and biases. I see that Dr. Collar is typing, but I can, kind of comment on that as well, that I do worry about biases in this because not only just for younger patients, my concern is that, we are selecting with people who have not had, interactions with, legal problems. Patients have not had, other impacts on their social life, or have kept their job. And I worry sometimes that this leads to us selecting more high functioning patients. I think that we need to continue to monitor for this and identify any, barriers or, inequities that occur because of this pathway. But I think it's an important question that we do need to continue to look at, so we don't just select for affluent or even, white or people near city versus rural, extending resources and helping people who are don't have the same access to support and financial abilities. We got to make sure that we don't just select for certain groups. I think that's a great question. Someone asked about if TIPS, does it stop the transplant eval process? No, the TIPS does not stop the eval process. And actually, sometimes we'll even evaluate someone before TIPS. So ultimately, a TIPS should not have an impact on the transplant process. The one thing we do worry about TIPS is making sure the location doesn't affect our surgeons, which is something we review. But obviously, if they need a TIPS, you can reach out to us to make sure it's safe, but it does not stop the transplant process. Those are all great questions. And I think, a lot of what we're doing right now, as far as alcohol and transplant, is really trying not to put up arbitrary barriers, really trying to find out more objective ways to select patients and understand that some patients will go back to using after transplant, and trying to identify those people, but also treat them and treat this medical diagnosis alongside transplant, and understanding that, destigmatize, and while we do need to protect the grafts and do need to protect our patients, we need to treat both things at the same time. And, if we waited, X amount of time for all transplant patients, maybe we would know when to go back to drinking. We may miss the opportunity, as we've seen, to select patients who are going to do really well after transplant. And so we're here trying to find those patients. And really, as you guys, as referring providers and people in UCH and elsewhere, and, referrals are always encouraged, as long as the patient's not drinking and, and is interested, get them to us and let us help figure out timeline to transplant and things like that. And if they don't need a transplant, that's a good thing. And that doesn't mean the referral was unnecessary. So someone just asked about the breakdown of sex and gender of patients selected for transplant at UC Health. I do not have that available to me right now. I wonder if someone else in our group, if they're listening right now, has that data available, who can send that out. But I do not have that at the top of my head right now. I apologize. A lot of our transplant outcomes are available at the SRTR, and we actually have a lot of this on our UC Health website as far as some of our major outcomes. So obviously, feel free to reach out, and I can try to answer that question later if one of my colleagues doesn't have them available to provide it right now.
John, if you don't mind, this is Avash Kalra, one of John's colleagues. That information is actually available via the SRTR database nationally. In terms of wait list registrations, it's about 61% male, 39% female. That's across all centers in the United States. And for our center, from 2021 to 2022, the numbers were almost identical. It was 60% male, 40% female.
Thank you, Avash. All right, looks like we got another question here. Would it be helpful for an inpatient referring provider to have a SALT score or mental health eval done before we contact a transplant center? And are there any pieces of data that we are commonly left out of initial referrals that we can prepare better? It's a great question. So, the score, again, a lot of these scoring systems are more are attempts to, objectively or quantify these risk factors. I would say in general, the score itself would not change our change our decision on a patient. We may sometimes, we more defer to our social work and our psych team to kind of integrate all these factors and recommend, counseling, or how long a counseling, or, what their risks are overall and how much intervention, do they meet our high risk pathway? Things that, you can do specifically, as an outpatient, again, PET tests, continuing them initially and then monthly is really helpful for having negative tests. That goes a long way in our discussions with our selection committee to show sobriety. And then the other thing is just getting them engaged with alcohol counseling, individual alcohol counseling. And again, a lot of times patients have a lot of questions, like they want to find the right counselor and do the right type of counseling. And I think in my standpoint, really, and from our discussions in our selection committee, it's really more about them engaging in the process, showing initiative, showing insight, establishing care. Obviously, the therapy itself is essential to preventing ongoing use, but documented sobriety, along with establishing with a counselor, it goes a long way for showing, again, insight and commitment to this process that goes a long way for making someone a transplant candidate. Really, these patients, don't need to be perfect at the time of transfer. But we do want, obviously, those are kind of some bare minimum asks that we can do to, while getting them up here and medically trying to optimize them for transplant and figuring this out. The other part of it is the inpatient referrals. I think the best thing you can do when you call one of our doc lines is, again, we're not expecting you to be a transplant hepatologist or a transplant psychologist, but really, looking at these questions that we ask and these requirements for the alcohol high risk pathway. And if you're ever unsure or anything, feel free to reach out and discuss the patient. We're always available. But, I think really asking these questions and being able to, these are that questions that I will and my colleagues will ask you when we're discussing this patient or these patients over the phone. And if you know these, it speeds up the process. It allows us to get the ball rolling, and allows us to expedite their care and get them here, rather than having to go back and talk to the patient. And really, we're not trying to be difficult. These are just the, requirements that our centers has decided upon. And if you have all these ready for us and, these detailed social history, it goes a super long way about getting them expedited to the eval and transplant that they need. Any other questions or anything else just anyone has to about alcohol-associated liver disease, transplant, alcohol high-risk pathway, anything like that? I'm happy to answer. Well, if that's it, those are all great questions so far. If you need anything, here's my email address right here. Or obviously, you can reach out through DocLine at any time through UCH to get a hold of our on-call provider. But I'm happy to answer questions anytime, or if you even just want to talk about a theoretical patient or what you can do for your panel, please reach out, and I'm happy to talk anytime, as well as obviously my colleagues as well. Perfect. One other thing that we just wanted to highlight today is our upcoming Rocky Mountain Highlights in Gastroenterology and Hepatology here. The registration is free and should be going out soon. It's going to be on Saturday, August 5th. Here at our brand new Anschutz Health Science Building. So it's going to be very nice. But if you have any questions, reach out, or obviously feel free to register and join if you can. All right. Well, thank you for listening to my talk again today. And I appreciate you guys' interest in alcohol and transplant. It's a lot of what we're dealing with right now. And I know this is a huge burden on everyone in the community, and we're looking for better ways to take care of these patients. So it was great you guys were here, and thank you for coming. Avash, anything else you need from me?
No, thanks, John. And I think Lindsay put the information in the chat about CME and nursing credit as well.
All right. Well, thank you, everyone.